All right, a warm welcome to everyone in this special event, whether you are in our Zoom events or whether you are following on Facebook. So this is the special event which we are organizing. We're very pleased to welcome the International Rescue Committee to this special event to discuss non-communicable diseases, NCDs, in humanitarian settings. Because over 750 participants registered for this event, we have decided to do what we do when we get exceptional turnout for these special events, which is to also broadcast them on Facebook Live. So you can see the link here. If you are in the Zoom room, don't leave. But if conversely, if you have colleagues who have trouble getting on, and their Facebook works just fine, you can steer them to Facebook and they can watch the event. I want to acknowledge Sibiri Paul Widraoko and Nora Benbernu, who are watching the live feed on Facebook as well. If you are in Zoom, you get to ask questions directly. We'll be keeping an eye on the chat in Facebook as well. Right now, so to answer the francophones who have joined this event, first of all, thank you for joining. Cet événement sera en anglais aujourd'hui. So if you're unable to follow the English, we fully understand, and of course we strive to offer our events in as many languages as we can. Very pleased to introduce our two panelists with whom we're going to have a conversation. So we decided to move away from webinar style presentations where someone speaks through their slides. There's a time and place for that mode of presentation, but today we want to really have a conversation with Laura Miller and Dr. Shanthi Mendis. So I want to welcome both of you and thank you for making the time to join us to discuss this important this important issue, or the intersection of non-communicable diseases and humanitarian settings. If you're here, you obviously know a little bit about the Geneva Learning Foundation. We really have been organizing such special events for years. Everything we do is digital. That's worth mentioning in today's special circumstances. Laura, would you like to introduce the International Rescue Committee? We're really pleased that you accepted our invitation to share about your work and about IRC's action specifically in this area.
So the IRC, we work to support people who've been affected by conflict and disaster, and helping them to regain control of their lives. And so IRC works in health. So we work in about 40 countries around the world, including in the U.S. Because in the U.S. we work in 25 states in the U.S. supporting refugee resettlement, and then we work in about 40 additional countries supporting programs that support improved outcomes in health and protection and safety and education and economic recovery and development, and also working on system strengthening in all of those countries. So I work in the health unit, and within our health programs, we're in about 25 countries around the world and supporting a range of primary and reproductive healthcare programs. And it's, it really varies based on the context, whether it's from supporting mobile health teams in a place like Yemen, or supporting or really working through the Ministry of Health and supporting system strengthening in a country like Sierra Leone. So kind of the modality of work we support is really different based on the context.
Great, thank you so much, Laura. For participants who are just joining the room, we have started, and I have kept deliberately the poll on screen, so you can tell us a little bit about who you are. Right now, it looks like we have more than half of the participants in the room who are from the subnational, and especially more than a third from the district or health facility level. So we have in the room many, obviously, medical and health professionals. A third are doctors. Almost 20% our nurses. I'm going to share the poll in a minute, and we'll ask my guests to comment on it. What does it mean to be able to bring together in this way participants from all over the world? In terms of organizational affiliation, almost a quarter are from the UN. A few are from the Red Cross, Red Crescent, almost 20% from international NGOs, and then there are some participants from university or other research institutions. So let me end the poll now, and we can spend a little bit of time on it. I've already read out some of the results. Let's start with Dr. Shanthi Mendis.
Yes, I'm very pleased that quite a few of the participants are actually working in humanitarian settings, and some have in fact joined because they are interested in non-communicable diseases, and many are working at the regional and at the subnational level. So I think overall, we have a cross-section of doctors, nurses, health workers, and other humanitarian workers. So I think it is a wide spectrum of people, and I would like to welcome all, and I'm very happy to see such interest.
I think it's interesting. It just shows a real diversity and interest among a very wide group of people in terms of kind of the level of system that they work in. And then I also think it's very interesting the diversity of professional qualifications, and also the organizational affiliation. I mean, I would wonder whether or not the other is a lot of governments, staff, so people who work in mental health within their own country. That would be interesting to know. So yeah, I think it's interesting. It shows we have a really, that we need to speak to a wide audience, because we have a wide audience today.
We don't know if it's the beginning, middle, or it's probably not the end of the COVID-19 pandemic. So I wanted to turn to Laura Miller from the International Rescue Committee to basically, can you tell us how a little bit about IRC's response in the COVID-19 pandemic, obviously working in many fragile contexts, many frontline contexts, and then how you relate this back to this question of NCDs and humanitarian settings that we're going to be addressing today.
IRC's overarching strategy related to COVID response really has three main components or priorities. So the first priority is to make sure that everything that we do, we're making sure that we're keeping our staff safe. So what that means from a health program perspective is that we're only asking staff to provide care in contexts where we're able to provide them PPE. So that's the first priority, staff safety.
How severe do you expect a crisis like this to be, to have in terms of impact for people whose main health issue is that of non-communicable diseases?
A lot of the humanitarian context of the world, people are living in dense and more densely populated kind of areas than than other locations, like particularly refugee camps. They're some of the most densely populated places in the world. The place that comes to mind the most is the camps in Bangladesh where the Rohingyas are. So I mean, I think we're extremely concerned about how this is going to impact the general population, and then also patients with NCDs, just based on kind of the double burden of vulnerability that they have. The first burden being living as a refugee in densely populated areas, and then the burden of also having this risk factor of having a non-communicable disease.
There is a participant in the room who has asked, who'd like to know the meaning of the acronym NCDs, and of course this is non-communicable diseases. I invite you to stay on to learn more about NCDs. Non-communicable diseases are the leading causes of death and disability worldwide, including in low and middle income countries. You can see a few more bullet points here. So we're first going to chat with Laura Miller from the International Rescue Committee, who has just issued a package of essential non-communicable disease diseases interventions for humanitarian settings. Another acronym is PEN-H. The H is for humanitarian, building on an existing guidance from WHO known as the PEN, of which Dr. Shanthi Mendis was at the time the principal author. So Laura, could you tell us why is the International Rescue Committee taking action on non-communicable diseases, specifically in humanitarian settings, in fragile contexts? What exactly are you doing and how? And not necessarily the level of detail, but the big picture of what you are doing and how and why is what we're interested in.
IRC is a member. There's a group of kind of an informal working group on NCDs in humanitarian settings that was started in 2015, and so we're an active member. Over the last five years, really, several countries affected by conflict have had a higher burden of NCDs. So specifically Syria, Libya, Yemen. And so these conflicts have continued for many, many years, meaning that there have been many more people who have died kind of unnecessarily due to NCDs. And so I think these conflicts specifically have really raised the issue around NCDs within humanitarian settings. And then we've also seen that in refugee camp settings, thinking of Kenya and Thailand, places where refugees have been living for 2 to 3 decades, and that have been exposed to really unhealthy risk factors such as inability to access healthy foods or lack of space to be physically active, and increased stress resulting in use of tobacco and alcohol. We've also seen increasing rates of NCDs, and then we also just have the epidemiological shift that's happening throughout low and middle income countries in terms of increasing rates of NCDs. So I think based on just kind of the increase in the awareness of NCDs as a major health issue within our health programs, we as IRC had to prioritize this as part of our mission of making sure that people are healthy within humanitarian contexts. And I think that just in terms of why we worked on the PEN project is, I think that one of the challenges is kind of, two of the kind of big challenges in terms of NCDs within humanitarian settings is, one, there's a real lack of evidence about what works in humanitarian settings, and it's really difficult to do proper research in a lot of the places where we work, even though we do try. And a lot of the evidence base that exists is really from other contexts, including other low resource contexts, but some of that really isn't applicable within humanitarian contexts where a lot of where things are just really different. And one of the things that's one of the other challenges is around that the clinical guidelines and standards really vary in countries and contexts. In some of the places where we work, there's Ministry of Health clinical guidelines. In other places, they choose, clinicians use MSF guidelines. But in a lot of the countries where you have extremely weak health systems or failed states, actually the clinical guidelines have not been updated in many, many, many years. So they don't represent kind of the best practices and kind of the latest evidence around how to provide care for patients with NCDs. So that was part of the rationale of why there needed to be this PEN for humanitarian contexts. So I guess I'll stop there, and I'm sure Dr. Shanthi can say a lot more on the specifics of the PEN since she was the principal author.
Great. Thank you, Laura. We are indeed going to be turning to Dr. Shanthi Mendis. If you work in humanitarian settings on non-communicable diseases and would like to share your experience, we'd love to hear from you. We'd love, of course, to hear your voice and to feel that there are indeed people connected from all over the world to this session. Dr. Nabil Liaquat, welcome. Please tell us where you're connecting from, please.
Thank you, Rada. I'm connecting from Pakistan. Can you hear me?
Yes, loud and clear. So tell us, how are you involved with NCDs, NCD care in the humanitarian setting?
Okay, actually, basically we are working at primary care level, and in Pakistan we have few Afghan refugee settlements, the Afghan camps in few of our cities. So it is in a country like Pakistan where already we have a weak and fragile health system, and then we have those AR camps there. So working for those camps and having this non-communicable, because it's already that system, the weak and fragile health system, it's not just for those AR camps, it is also for other population as well. So I just wanted to know that it is excellent that we have this package for essential non-communicable disease intervention for humanitarian settings, but can we use this package for the population surrounding them? Because it is almost one or the same thing, like if the camp settlement, definitely the people are living in closed groups and everything. But if you look around those camps, if you look around those settings, the people, their condition is also very bad. So it's just I wanted to know that definitely the author would have thought on this. So that's from my side. Thank you.
I see there are around 10 questions in the Q&A currently. And let me look at some of the questions. So Aja Chinonye Peace asks, is the PEN-H available in Nigeria, or has it really not been introduced here? So yes, indeed, we were going to get to that towards the tail end of the event, but let me ask Laura Miller now, what's the availability of this package? Who is it for? Where do we find it? We are hoping, of course, to share it with participants in this event.
We can share, there's a PDF version of the PEN-H toolkit. It's also available in French and Arabic.
And let's go to Mohib Ibrahim.
Yeah, actually, I'm connecting from the northeast part of Nigeria, where we are working in a humanitarian situation, a complex humanitarian situation, where a population is caught up between in hostilities between the security forces and non-state armed groups. And actually, I'm working in immunization and MNSCH delivery in those areas. The non-communicable diseases issues in the Northeast has to do with the people in need. And when we estimate the people in need, you find out that a lot of people fall within the age group that are actually not vulnerable to non-communicable diseases. And when we have paucity of resources, we feel that we have to prioritize in the areas where a lot of people are vulnerable. So the population in needs are mostly, in Nigeria, you find out the population is mostly young, and they are more susceptible to non-communicable diseases. And we have paucity of resources. And so we have to prioritize and look at the number of people in need so that these resources will be committed to those areas. Most of the people that have non-communicable diseases are a little bit advanced in age, and you have that some of these diseases are mostly chronic, and then there is no way you can be able to commit resources for a long time to be able to actually reduce the impact of those diseases in those particular people.
Thank you, Mohib, for this perspective. I know Dr. Shanthi Mendis would very much want to respond.
So there are many premature deaths due to non-communicable diseases, and it is a development issue for all developing countries. And even though you prioritize infectious diseases, you cannot afford to not focus on non-communicable diseases, because it will hit your development targets if you do that. So at least at the beginning, you certainly need to prioritize, but prioritize in such a way that you prevent premature deaths, people dying from under the age of 70 at least. And to do that, you need to put in place policies and disease management projects related to non-communicable diseases. Population-based interventions to prevent NCDs are quite inexpensive in comparison. It's worth noting that.
A question from François Gass. According to your experience on PEN-H, and I know IRC has done some field testing, where is the biggest challenge? A package of interventions prioritized is always useful, but also how useful it is depends on its effective implementation or execution.
It's a great question, comment. Yeah, and I think that we learn over and over and over again that the development of these types of guidance is only as good as their kind of the implementation plan for their rollout. So I know for us, kind of the plan is to be able to now try to develop a rollout plan for this, which will include, training people at national level, and then to be able to cascade that down to primary healthcare level. And we're hoping to be able to learn a lot from that experience in terms of measuring competency, pre-training, post-training, and then also measuring kind of changes in care practice at the health facility level, pre-training and then after training, and then 3 to 6 months after training. So we feel like that's really the best way to measure the effectiveness of the rollout. But of course, that's also resource intensive, but that's our current plan.
Why worry about non-communicable diseases, NCDs, during a humanitarian emergency? Historically, in humanitarian situations, it's primarily or first and foremost the risk of infectious disease that was the focus of emergency response. So why should it be different? Why is it different?
That is a very important question. In fact, one could argue that infectious diseases in humanitarian emergencies should receive also the attention and focus. But what has happened over the last 10 years or so is that non-communicable diseases have increased in prevalence worldwide. It's worldwide. That's very important to note. It's not just in high-income countries. It's in all countries of the world. And if you take, for example, common conditions like hypertension or diabetes, the prevalence is very high. Hypertension prevalence in any part of the world currently is about 25%, around 25%. And diabetes may vary from about 6% to 15% in some populations. So when humanitarian emergencies occur in any part of the world, in any country, the people who are caught by this emergency situation will also have non-communicable diseases in large numbers. There will be people affected by NCDs, some diagnosed, some in fact undiagnosed. So it's very important to focus on non-communicable diseases as well in order to prevent preventable deaths during the emergency situation, because due to the stressful situation and also because diagnosis and treatment and referral, these are difficult in emergency situations, people with NCDs will have a very difficult time, and it will be very challenging to look after them. So that is why we need to focus on NCDs in all humanitarian emergencies.
Laura Miller explained how it's really the crisis in Syria that got the International Rescue Committee to really give due consideration to this question of NCDs. So Syria, a middle-income country, that seems to indicate that NCDs might be a problem of more affluent or certainly not the poorest countries. So is that true or is it a myth? Can you set us straight on this question?
That is very important to clear this issue. The important thing to understand is non-communicable diseases are there in all countries at all levels of development. People suffer from hypertension, from diabetes, from cardiovascular diseases. In middle-income countries, the prevalences are even higher now. In high-income countries like the United Kingdom and other countries, in fact, over the last 10 years, cardiovascular disease prevalence, the mortality has gone down. But that is because of the very good policies related to prevention as well as disease management, early detection, etc. But middle-income countries, in these countries, it's another story. The populations are exposed to high levels of behavioral risk factors like tobacco use, harmful use of alcohol, physical inactivity, and an unhealthy diet. And obesity levels are going up, diabetes levels are going up, hypertension prevalence is going up. So the prevalence of NCDs definitely are on the rise in middle-income countries, and low-income countries also now have increasing prevalence. But the important thing to remember is that when you get NCDs in middle-income countries and low-income countries, people are diagnosed late, and therefore their fatality rates are higher, partly because the diagnosis is late, but also because health systems are not geared to handling NCDs.
You were, in your time at the World Health Organization, you led the development of the WHO package of essential non-communicable disease interventions, known as the WHO-PEN, for primary care in low-resource settings. Can you tell us, what is this package? What is it about? How can it be used? How has it been used by practitioners? For what purpose?
So the WHO PEN package, and that acronym stands for WHO Package of Essential Non-Communicable Disease Interventions for Resource-Constrained Settings for Primary Health Care. And that package was developed when I was working in WHO. There was a great demand from WHO member states, particularly lower and middle-income countries, for tools and for technical assistance in relation to taking care of people with NCDs through a primary health care approach. In other words, early detection, diagnosis, management of non-communicable diseases is quite challenging when resources are constrained and health systems are weak. So the member states demanded and that technical assistance be given, and this package was put together to provide guidance for primary health care physicians primarily. And the package has simplified evidence-based protocols and many other tools like which diagnostic tests should be available, what are the core medicines that should be available. This kind of guidance is provided in the package. And it is a package that can be implemented in low resource settings, but a package which will ensure that doctors will be able to provide quality care. So the standards are maintained, it's evidence-based, but the guidance is simplified and the interventions are chosen which are not only essential, but which are cost-effective, so that countries will be able to increase the coverage of people who are suffering from NCDs to provide them care, but do it in a way that is affordable to them and sustainable, because continuity of care is key for NCDs. It is not a question of just providing some medicines one time. It is most of the time a lifetime of treatment. So it's quite expensive to do that. And unless you choose cost-effective interventions and do it in a way that it is sustainable, countries won't be able to really get on top of the issue of managing NCDs.
What level of evidence is required for a recommendation to be included in such a guideline? And then we'll talk about why this might be difficult in a humanitarian context.
WHO uses a very stringent process when developing guidelines, particularly for clinical care. And the process is not only quite long, but is also quite difficult in terms of cost as well as labor needed. So before one develops a guideline, one needs to see all of the research related to that particular outcome. Say if you're talking about diabetes, then you need to look at the research related to diabetes care. And then we have to do systematic reviews, collect all of the evidence, and then evidence is graded. Is the evidence good or not so strong? And then based on the quality of the evidence, recommendations are issued, and the recommendations are also then given a grading. Strong recommendations, weak recommendations. In other words, the recommendations, when implemented, should benefit the person who is subjected to the recommendation. So that's a evidence-based guideline, and there's a very stringent process in developing that. So then we developed several guidelines before we went down to the protocol level. What about the PEN-H, or the package of essential NCD interventions for humanitarian settings. Now, one of the difficulties was that when it comes to clinical care and particularly treatment, one has to get evidence from clinical trials. And the trials that have been done, practically all of them, have been done under stable conditions. You don't have clinical trials that have been done in humanitarian settings. It's even not practical to do so. So in a certain way, one could say the evidence is extrapolated to humanitarian settings. That is one challenge. The second challenge is that in humanitarian settings, there are resource constraints in relation to health workforce, in relation to diagnostics, in relation to medicines, as well as referral. So when there are all of these challenges, developing a guideline which is evidence-based becomes quite difficult.
With humanitarian settings or humanitarian emergencies, there are many unknowns, potentially extreme resource constraints, and every emergency, every context is different. So how can an evidence-based guideline be relevant given everything that might be different? How can you talk about a standard when you have when no two situations are the same?
You're quite right. I mean, every emergency situation is different, and there are so many unknowns. That's quite right. But one could argue that when you have a heart attack or when you have heart failure, whether you have it in an emergency situation or whether you have it in a stable situation, the pathophysiology is the same. What is different is how you're going to diagnose and manage. And that difference comes from the fact that resources are constrained. So, therefore, you could still apply evidence and develop recommendations and develop protocols, but the difficulty comes when you try to implement, which means that you have to go down one step further in simplifying what can be implemented in humanitarian emergencies. In other words, they have to be extremely simple, not only extremely simple, the protocols should be implementable. For example, with the medicines that the interagency package provides, or the diagnostics and the tests that you will use cannot be like in a stable hospital setting. It has got to be very, very simple, the most basic, and sometimes you might have to resort to clinical diagnosis without even special testing. But the fundamental objective is saving lives. You have to save lives, and you have to save lives however you can by applying the evidence to this special situation. And it can be done. And that is what the protocols in this package do. Simplified recommendations which are implementable with very few requirements of medicines and diagnostics.
Some humanitarian health practitioners may feel that they rely on their intuition, on their field experience to figure out what to do in an emergency, including for NCD care. They might say the evidence-based guideline, it may be important, but it takes too long to develop. It's not practical enough, and it can't account for the situations that I'm actually confronted with. It's too general. What would be your response to that?
Yes, that's an important comment that you make, that some people have this idea that intuition and experience count a lot. I would agree in a sense. When you look at evidence, what is evidence? Evidence is clinical experience and patient values integrated with research evidence. That is scientific evidence for clinical care. So one could argue that when you talk about evidence, you are actually adding experience when you are issuing recommendations. The recommendation packages patient values, clinical experience, and research evidence all together. But intuition alone or doing something with nothing is not possible. Let me explain. If you don't have
basic medicines, it is not possible to save lives, even in emergency settings. You may be able to do something in the interim till you refer the patient. In fact, there is a protocol in the package for that. But in most NCD emergencies, you need specific medicines. And unless those medicines are available, there's nothing that you can substitute and hope that it will work, because patient safety counts a lot. And also there are ethical and moral options for practitioners to do what is safe for the patient. I mean, you should do no harm, but try your best to save lives. So intuition alone will not be enough. You will have to have some core facilities, core medicines. Of course, experience helps, but wherever possible, package that with evidence.
Is there a need for the PEN-H package? Why not just use the existing PEN package? What's different about and specific about PEN-H?
Yes, so PEN package, the WHO PEN package, was developed for primary care under stable conditions. In other words, if you look at the WHO PEN package, it has protocols that one can use in primary care, particularly for early detection and management of diabetes, hypertension, bronchial asthma, and even there is early detection of cancer protocols. But it does not have protocols for acute emergencies like diabetic ketoacidosis, like acute coronary syndrome, heart attacks, status epilepticus. Those protocols are not in WHO PEN, but they have been included in the PEN-H package because in humanitarian emergencies, health workers will be confronted by these emergencies which can cost lives. And people can die of, say, a diabetic emergency or a stroke or a heart attack, and you've got to do something. You can't do everything that you would do under stable conditions or when you are in a hospital, but you have to do something in order to try to save lives. So the package has protocols for all of those common NCD emergencies, and these are not there in WHO PEN.
During the Ebola crisis response in 2014 and 2015, more people died of HIV, TB, and malaria due to interruption of services. So what do we know? What can you tell us about what we know about increased NCD morbidity and mortality in humanitarian settings?
So the NCD morbidity and mortality are likely to increase in humanitarian settings due to several reasons. One is the stressful condition itself will make people sometimes develop acute exacerbations. Bronchial asthma is a good example. And if you have bronchial asthma, if you are stressed out and worried, and practically all humanitarian emergencies are very stressful, people develop acute exacerbations. The same is true for heart attacks. It's very well known that acute stress can precipitate these conditions. And on top of that, for non-communicable diseases, it is very important continuity of treatment. If you have diabetes or if you are a patient with heart disease, if you don't continue your treatment, it's very likely that in a day or two, your situation will now exacerbate in terms of either blood sugar going up or the blood pressure going up, because the medicines keep these diseases under control. They don't, most of the time, cure the diseases. They control the diseases. So in humanitarian emergencies, when medicine supplies are disrupted and patients don't have access to their regular medicines, their condition is going to get exacerbated, and they can actually have acute emergencies like a heart attack or a stroke or renal failure and succumb to those emergencies. And that's why the the morbidity and mortality of people who have NCDs, they get worse in emergency settings.
Let's come back to some of these issues and questions about PEN-H, and let's talk about the clinical guides within the kit. First of all, which diseases or conditions are addressed by PEN-H?
In terms of the clinical guides, which are in part 2 of the package, part 1, by the way, just introduces the package, how to use it, why the package has been developed, and in part 2, the clinical guides are given, and the clinical guides address cardiovascular diseases, mainly heart attacks and strokes, hypertension, diabetes, bronchial asthma, chronic obstructive pulmonary disease, and epilepsy. In other words, the prevalent, the common non-communicable diseases. And within the guides, for each of those conditions, several questions are answered. What is the condition? What causes the condition? How does a patient with this condition present? In other words, what would the patient complain of? What signs will you see? And then it goes on to tell you how the condition is diagnosed, how it is treated, what the complications could be, and finally also how it can be prevented. So all these questions are answered in the clinical guide section for these 4 major non-communicable diseases: cardiovascular disease, including hypertension, diabetes, chronic respiratory disease, and also epilepsy.
What is different in these clinical guides that you're specific to humanitarian settings?
So what the clinical guides try to do is to introduce these conditions in a very, very simple way, recognizing that some of the health workforce who have to provide NCD care in humanitarian emergencies may not have had formal NCD training. That being said, the package, in fact, assumes that all the doctors and nurses who uses the package would have been given formal training on the package, and that would be necessary if the package is going to be properly implemented.
We'll come back to the issue of training and how to build the competencies or the capabilities needed to make effective use of the package. But there's several scenarios. There's a patient with NCDs who may present with an emergency. That's obviously the most acute, the most critical. There's someone who may have a condition and be suffering, but it's not an emergency or life-threatening emergency. And then there may be an acute condition that's not NCD related, but nonetheless life-threatening, for example, sepsis. Can you help us think through these 3 different types of situations? If I'm a humanitarian health worker, how can PEN-H help me make the best decisions possible for these types of situations?
That is a very important question. If the package is going to be useful, the doctors and nurses should be able to use it for the question that you raised. So, when you take non-communicable diseases, there are certain emergencies that are likely to occur, particularly in the acute response stage, in the first week or so. They will occur later also, but people will die from NCDs within the acute phase, the first week or so, from acute NCD conditions like acute coronary syndrome, that is heart attack, acute heart failure, stroke, hypertension emergency, diabetic ketoacidosis, acute severe asthma, exacerbation of chronic pulmonary disease, and also status epilepticus. Now, these few conditions are emergencies where, unless you detect them and you immediately treat them, these patients most likely will die. So that is why in the package there's a triage section. In other words, how to recognize these conditions and give priority treatment to them. And the way they present, the symptoms are given for these few conditions, to triage them, to separate them out, to first of all recognize them, and then separate them out and to provide them priority treatment. Then as opposed to that, take a patient with mild hypertension or stable diabetes. Now that's an NCD condition, but you don't need to provide the patient treatment within an hour or two. You can arrange medicines to be supplied to these patients in a day or two, unless of course the patient is on insulin for diabetes, but otherwise there's no great emergency, but you have to manage those NCD cases. Then you have also what you mentioned, sepsis or infections. For example, a diabetic patient may be having also an infection. That is quite urgent to treat. And on top of that, you have many other NCD conditions, like, for example, arthritis or backache. Those are also common complaints and diseases of people with NCDs, but they are not emergencies. They need to be provided care, but not immediately, not in the first few hours of the emergency. But you can organize treatment and care to be given to the less acute cases in a day or two. When medicines are available, when doctors come, when diagnostics are available, and so on. So it is important, this separation of the acute NCD emergencies, which will kill people, and to save lives, you need to be able to triage them and provide treatment, and then the less acute and also non-NCD conditions.
What can or should humanitarian health worker, doctor, or nurse do? What are the options? What are the interim measures when you cannot refer an acutely ill patient with, say, cardiovascular disease? It's just not feasible. There's no hospital, there's no way to reach the hospital, or the hospital has been destroyed, or there was no hospital in the first place. What are the interim measures? What can you possibly do there to actually save lives? And how can this package actually help you identify what action, what decisions to make, what actions to take?
Yes, that's an important question you raised, because in humanitarian emergencies, particularly in the first few days in the acute phase, health workers will be faced with this kind of situation. No medicines, no referral facilities, as you explained. So there is a flow chart, 3.2 to be specific, on these interim measures. What can you do? So let me mention a few things that are contained in that protocol. For example, if the patient is breathless and the patient should be referred to a hospital for care, but has a condition which makes the patient very breathless. What can you do? You cannot refer because the roads are blocked and there's no way to get the patient to the hospital. So if the patient is breathless, you could sit the patient up. You can give some oxygen if oxygen is hopefully available. At the same time, if the blood pressure is very low, you can raise the foot end of the bed. It's something that we do in clinical situations like that. And then if there's a delay in referral, an intravenous line is set up for most acutely ill patients, and then you have to make sure that the patient gets intravenous fluids during the period that the patient is unable to take anything orally. And also you have to make sure that the vital signs are monitored, like the level of consciousness, the urine output, the pulse, the blood pressure, and to the best of your ability, also make sure that the patient doesn't aspirate the secretions. That often people who are very ill, they are not really conscious about breathing and also aspiration, and secretions in the mouth can go down to the lungs and cause pneumonia, and sometimes patients even succumb to that aspiration and blockage of the respiratory tract. So you have to prevent aspiration and make sure that you take care of the patient until referral becomes possible. And then there are protocols for each of these acute conditions like bronchial asthma or heart attack, stroke, etc. And there are certain things in those protocols one can still do until referral becomes feasible.
Community health workers play an important supportive role in the provision of care for NCDs, or at least they can or should, according to PAN-H. Can you tell us how the PAN-H package can help community health workers?
So, community health workers can play a very important supportive role in emergency situations because doctors and nurses are going to have a very heavy load of clinical responsibilities, providing clinical care to large numbers of patients. And community health workers can certainly be supportive in this situation. And the package has, in part 3 of the package, there are protocols, there are in fact 8 protocols, giving guidance to community health workers on what they can do to counsel patients, to give advice, to counsel for tobacco cessation in relation to harmful use of alcohol, diet, physical activity, use of medicines. And there's also a protocol which helps community health workers to follow up people with hypertension. And another protocol which will be useful to community health workers if a patient has an epileptic fit, or if there's an epileptic patient, what kind of advice could one give? And this protocol provides information to the community health worker, which the community health worker can pass on to the patient. So those are useful for their supportive role, to strengthen the supportive role. And there are also self-care guides in the package, and community health workers can give these self-care guides to NCD patients. There is a self-care guide on epilepsy, and there is a self-care guide on prevention of heart attacks and strokes, and also early recognition of heart attacks and strokes. So that's very useful information, and community health workers can contribute to communicating this information to patients.
We heard from a participant who works on maternal and child health in the northeastern part of Nigeria, so in a humanitarian setting, and in a country which has declared that maternal and child health is a health emergency. And he basically described a situation in which he felt that he had to prioritize, and that NCDs could not be, in his context, a priority. He considered that these were lifestyle, diseases, and that did not necessarily feel that as a health worker, it was his role to get involved with changing people's lifestyle, or that was an entirely different kind of pursuit.
I think what he said was that maternal and child health is such a major problem that it should be prioritized. I would completely agree with that, but I would also argue that even in Nigeria or any country in the world, there are patients with non-communicable diseases being treated in hospitals. And that is extremely costly, and it also doesn't give a good return. Let me explain. For example, if you have a patient with diabetes, if you just neglect diabetes, if you neglect hypertension, you're going to have to manage people with complicated diabetes, complicated renal failure, complicated heart attack, strokes in hospitals. That's extremely costly. And that's going to take away your money and resources that you can in fact use also for maternal and child health care. You're not going to just let people die at home. When they get diseases, they come to hospital, and the government, in some way, spends on them. So the correct way to do it is to, as much as possible, prevent. And prevention is, in fact, not expensive. You cannot do prevention without any resources, but definitely prevention is much less expensive than management. And the second point, now, when it comes to prevention, government policies go a long way. Whether it is to promote physical activity or healthy diet or tobacco cessation, it's not just changing behavior by the person, but the government has to set policies in place so that the environment is conducive to behavior change of people. This is important to recognize. And the second point is that by prevention, then you save money, and this is also a major development issue for countries like Nigeria. So if you let people die prematurely under the age of 70, you are losing your breadwinners of families, and this means that the income suffers, the family income suffers, and there is also the costs related to taking health care for these chronic diseases, which are costly, long-term, going on and on and on for many years. So for all those reasons, it is important that NCD care is in some way taken on board when you talk about providing health care. It's just not only maternal and child health, certainly it should be prioritized, but you cannot ignore NCDs because the populations are aging. Even in Nigeria, it's now not the same demography that you see. With time, the populations in all countries, there are a higher number of adults and elderly people. And as you age, you are also more prone to develop NCDs because age itself is a risk factor. And on top of that, there are very cost-effective ways of controlling behavior and also motivating people to change behavior. So it is not just maternal child health only, but it should be both, certainly giving top priority to maternal and child health services.
The PAN-H package is being made available by the International Rescue Committee, the IRC, to many fragile contexts. It's also going to be publicly available online. So why would you say that training is needed? Could it not be sufficient for a doctor or nurse to simply download the package and begin to use it? Why is training needed?
I think training is going to be absolutely essential. I say that also with the experience we had with the HUPEN package. When we developed the HUPEN package, one of the first things that we did was to have training workshops in all the countries who wanted to pilot the package. Because training is not just reading or downloading by the health workers the material that is available. Oftentimes, you need to not only explain, but also have case scenarios discussed in order for the people to understand the protocols. Because even though the protocols are simple and it's provided in a step-by-step fashion, it is important for the person to learn by doing, by simulations, and also by sharing and sharing experiences, between them. So through either workshops or maybe virtual workshops, it is necessary to have training for a certain number of hours, and also to test beforehand and also after the training is given whether the person has actually assimilated the knowledge. But of course, assimilating the knowledge is not the same as implementing it. That's another step. And there, in fact, when it comes to training on these kinds of packages, you need to not only train them in workshops, but also see the actual implementation by following through the health information information systems. You can see how the patients have been taken care of. Was the protocol actually implemented as it should have been? And that means sometimes you need to really go down to the level of facilities and supervise. Supervision is extremely important. Supervision in order to give the workers information that will help them to perform better, not in a punitive way, but to perform better. Where did they make mistakes? Where could you do better? And even in some countries, they give incentives for implementing the protocols as they should be implemented. So training is extremely necessary. Didactic training, but also this kind of training when they are actually practicing, supervising and giving them feedback.
So, Shanthi, if you were to lead a group of humanitarian health workers, people who work in humanitarian settings, who are doctors, nurses, and community health workers, is this something that you would like to do, that you would stand ready to do, to support professionals in adopting and the use of PAN-H? And if so, how would you do it?
I believe that the Geneva Learning Foundation can play a role, and Reda, I think you might be able to come up with some innovative approaches here, because I mean, even if you were to do it using a virtual approach, because it would be too costly to have workshops getting these people to one place. If there is sufficient interest, and I think there was, judging by the number of participants for the event, I certainly would be quite interested in collaboration with other partners, maybe, IRC maybe. I would propose that the Geneva Learning Foundation leads such a training if people are showing sufficient interest. And I certainly would be quite happy, and it would be quite rewarding to be part of the training. And I think there is a need, because humanitarian emergencies, they happen without warning, and as you mentioned during the discussion, the conditions are variable, and countries are not sometimes prepared. Some countries have national guidelines, training, etc., but oftentimes resources are not there to continue to do this. So I think there is the need, and as you mentioned during the event, there was quite a lot of interest from a wide spectrum of people. So I certainly would be quite interested, and I think there is a need for it.
So could you tell me on a more personal note, so this would certainly be in line with the Geneva Learning Foundation's mission, but on a more personal note, is teaching people, whether doctors, nurses, or community health workers who are working in humanitarian settings, would you enjoy teaching them? Is this something that you are passionate about, ensuring that people not only adopt the tool or the package, but make the best possible use of it? Can you tell us why that would matter to you? You could also say your job is done. You've produced a package. Why do you care about its actual adoption and effective use through training?
I think that's a very, very important question for me, because before I even joined the World Health Organization, I was a professor of medicine teaching medical students, and it's one of the most rewarding jobs that one can do, to not only impart the knowledge, but also see that knowledge will be used to save lives. And I believe that is very rewarding, and that has been my experience. So I consider it something that I would love to do if there is sufficient interest, because a package can sit on a shelf, and people can download it, and it may not go very far. But if you, through a training process, get a group of people together, like through your scholar program. I know you have very many innovative projects on this. A similar project is started where humanitarian settings, those who are working in humanitarian settings and those who are interested and passionate about working in such settings, they get interested and they share the knowledge and they share their experiences and they grow through this sharing. The package can be a tool for that purpose because the package can only do so much. There is information, they are very useful, very essential, but implementation, learning from implementation, I think that's the next step.
We have only a few minutes left, and we'd like to make sure we get to the questions that are of greatest interest. So if you'd like to go to the Q&A, and then you see a little, let me turn the video back on. There is a little hand with a raised thumb like this, and if you click on that or tap on that with your finger, when you're looking at the Q&A section on your phone, you should be able to vote for the questions that are let's see. So we have a question from Stanley Joe. Okay, there's a question from Shalini Kar from India who asks, where does the funding for PEN-H come from? Do the governments of countries like Syria, Libya, etc. fund it, or are there UN agencies or donors who fund it? And that question has received two votes. Laura Miller, I think we see the USAID logo on the package. Can you talk about where is support for action on NCDs in fragile settings and humanitarian settings coming from? Who's actually helping?
The PEN-H was funded by the U.S. government from the OFTA part of USAID, and then in terms of implementation, supporting the implementation of NCD care in humanitarian settings. I mean, that's funded by a number of actors. I mean, as IRC, we receive funding from the US government, from DFID, the British government, from ECHO, from the Canadian government, so the Global Affairs Canada group, and then also we receive money from individual donors and corporate donors. So we're able to make our work possible through lots of different donors that we're very grateful to.
And would you say that the result of a change, growing awareness of the importance of NCDs in humanitarian settings, or is there a continuity here?
Yeah, I mean, the donors are not different. I mean, with the exception of like specific projects like the development of the PEN-H, we don't have a lot of NCD specific funding. For us, we have funding for comprehensive primary and reproductive health services, and part of those services is NCDs. I mean, I think maybe 5 or 6 years ago, there was less of a recognition of the importance of integrating NCD within the primary healthcare package, particularly in countries that still have a really high burden of communicable diseases and and high maternal mortality. But I think that that's really changing, and I think there's now quite a wide recognition that NCDs need to be part of primary healthcare. And so that they need to be funded like all other services that are prioritized at that level.
Okay, thank you very much, Laura Miller, for stepping in above and beyond what we expected to ask of you. Apologies to Dr. Shanthi Mendis for the internet. She's still trying to connect. Thank you, participants. I think there's some confusion amongst the francophones, who many of whom signed up for this event, which is clearly indicated as an event in English. Donc pour les francophones, malheureusement, cet événement aujourd'hui était uniquement en anglais, mais tenez bon, nous proposons de nombreux événements en français. We also offer special events in French. However, here, both our speakers, or at least Dr. Mendis, is not a native French speaker by any means. Thank you so much for your attention. This has been, we knew this could happen, and I'm so sorry that it happened this time with such great guests for this special event. There's always the risk that an event will be disrupted or make it impossible for a participant to connect, or a presenter as well. So thank you for your patience. I hope you have found this useful, and of course we'll be sharing the package itself with all of the attendees, and looking forward to your feedback about this event. Thank you, Laura and Shanthi, and thank you to all of the many participants who are now sending their greetings and gratitude in the chat. Look forward to seeing you for the upcoming special events, and hope that your connection will be will be there when you need it, whatever your other circumstances may be. Thank you, and goodbye.